Community bank. Where was I?
Evidence 1, 2, 3.
Oh, so evidence usually is supported by prospective randomized, trials. Type 2 is, some studies that are out there that shows it's beneficial, and type 3 is, well, that's just how we do it, right? And there's a lot of things in medicine is type 3. This is just how we do it. And when we have evidence-based medicine, we really should follow what evidence-based medicine is. And clearly there's evidence-based medicine for who gets prophylaxed in an ICU. So what patients get prophylaxed in an ICU?
Intubated patients?
So good. So patients with respiratory failure, what else?
Septic.
Can be sepsis, so it's respiratory failure, renal failure, and coagulopathy, right? Those patients, hands down, get prophylaxed. Then you go to the other risk patients, right? Patient with sepsis, burns, head injuries, right? So in general, most patients in ICU get prophylaxed, right? Now there are some that's not, but most patients, the patients that we don't prophylax are patients that are extubated, or awake and alert, or hemodynamically normal, who are on a diet. Those patients don't need to be prophylaxed. But what's the most common prophylactic agent? What is the number one prophylactic agent for stress gastritis that we should use in the ICU? What should we use? Protonics.
Pepsid?
Pepsid. Right, protonics. Okay. So the answer is that we should use an H2 blocker, right? Indication for the use of a proton pump inhibitor like protonics is A, the patient's got a history of peptic ulcer disease and takes that medication at home. B, has a GI bleed, right? And then the dosing usually of a patient with GI bleed is either Pepsid twice a day or a protonic strip, protonics twice a day or a protonic strip, right? But all other patients should be prophylaxed with an H2 blocker. Why? Why not just everybody gets protonics? Why an H2 blocker, not protonics? So, well, the mechanism of action is different, right? Because an H2 blocker, so there are 3 hormones that stimulate the stomach to secrete acid, right? So it's acetylcholine, gastrin, and histamine. And an H2 blocker it cleaves the histamine. That's what it is. H2 blocker, it's histamine. But it still doesn't cleave the other 2. Protonics, boom, shuts everything down, right? So protonics really shuts everything down. So they're 2 different drugs. They both work differently, right? Right. But what protonics predisposes patients for developing is C. difficile colitis. So that's why it's not the preferred prophylactic medication that's used to prevent stress gastritis, right? It should be an H2 blocker, not protonics, unless the patient has a reason to get a proton pump inhibitor, okay? So you can question that. You all see that, say patients on proton pump inhibitor, you say, well, why is that? And because sometimes what happens is that people just put them on, right? So you all, nurses in general, can look at medication and say, why is this patient on proton pump inhibitor? And the answer is, there's no good reason why, then why is the patient on an H2 blocker? Right?
Can you say that those 3 criteria for PPI? What did you say?
So the criteria for using a proton pump inhibitor: 1, patient is bleeding, has a GI bleed, right? 2, they're on a proton pump inhibitor at home because they got peptic ulcer disease, right? Usually it's bleeding or patients on proton pump inhibitor because they have peptic ulcer disease. It's their home medication. It's what they've been on. It's what they take. Right?
And what was number 3?
I don't know if it was the third one. There was no third one. There was only 2.
Only 2.
He said 3 for why you would use it.
Right.
Intubated patient.
Intubated,
Respiratory failure.
So the indication, right, is respiratory failure, renal failure, coagulopathy.
Yes,
That's
the indication.
Right. Then, and most of the patients we take care of have respiratory failure because they're intubated on a ventilator, right? Sometimes they have acute kidney injury, they have renal failure, they're on CVVH, right? Okay.
So those are the indications for prophylactically treating the patient, but the ones that you would treat with the PPI are then the ones with the history of the GI bleed that are on that medication at home,
Or
ones
now.
that are currently bleeding.
Correct.
Okay.
Okay. We're going to pass this. Poisons. hypertensive crisis, very straightforward. I just want to get to this last one because we're running out of time, which is important for us, which is intra-abdominal hypertension and abdominal compartment syndrome. Okay? So, from a nursing perspective, you're taking care of a patient. How do you know that a patient is developing an intra-abdominal compartment or has intra-abdominal hypertension? How do you know that patient is developing that problem? How do they present?
Physically, they
Yeah.
present like with a very taut, tight,
Distension.
growing abdomen.
Good. Very good. What else?
Low to no urine output.
Very good. What else?
Use respiratory wise, they're compromised.
Right. So
Mhm.
how does
Because
that?
of their
How's that reflected?
Well, if the patient is in the van, it's gonna be, give us a high
Peak pressure.
pressure.
Very good. So high peak airway pressures, right? It's distended abdomen, high peak airway pressures, hypotension,
High, yeah.
right? Hypotension, low urine output. Okay. Good.
What about
Very
if the
good.
patient is not intubated? You would be
It's
tachypnea.
very rare to have a patient with an intra-abdominal compartment syndrome that's not intubated on a ventilator. I mean, you can see these very distended abdomens in people who got cirrhosis that need paracentesis to take fluid off, and they can be compromised. Respiratorily they can be compromised, hemodynamically they can be compromised. But for our purposes, most of our patients, we're going to talk about patients. And why do people develop an intra-abdominal compartment? They develop an intra-abdominal compartment because A, they get really aggressively volume resuscitated, and so they have ascites. Not only that, they get bowel swelling and edema, right? And the bag here can only hold so much, right? Till it starts getting compressed, right? Okay.
They also get neurologically, like they get very agitated, confused.
They can. The answer is certainly they can. They can have discomfort, they can have pain. So now what do we do to treat somebody who's developing an intra-abdominal compartment? What do we do? Generally, what would be the treatment for that patient? So before we get to that, so how do we make the diagnosis? Let's talk about how we make the diagnosis. So we have a patient who we're caring for that we have a high index of suspicion that they have an intra-abdominal compartment. How do we make the diagnosis?
Bladder pressure.
Bladder pressure.
Blood
Very good. How do we do that? How do we do that?
We connect the transducer to the Foley catheter and we instill squiddy.
Okay, so you instill some volume of saline in the bladder, usually 50 to 100 cc's of fluid into the bladder. Good. And then when you measure arterial pressure and you measure central venous pressure, what's the most important thing of interpreting the right information? The transducer has to be where?
at the bladders.
So, but with somebody with an arterial pressure and you're measuring arterial pressure and central venous pressure, where does the transducer? Right, and where is that?
The
Second.
I know. It's
Second.
Right here.
It's the
Right here.
mid-axillary line. When you measure, so whenever you measure a pressure or a pressure inside a hollow viscus or an organ, right, you have to have a zero reference point. It can't be just up here or down here. It has to be a zero reference point. So with central venous pressure and arterial pressure monitoring, it's in the mid-axillary line at the level of the right atrium, right? But when you're measuring bladder pressure, where's your zero reference point?
At the
bladder.
level of the
So the
Symphysis
symphysis
pubis.
pubis, right? So at the level of the symphysis pubis, that's where the transducer goes, all right? So you set it up, you instill it in, you hook it up, and then you look at the pressure and you go, what's the number that gets everybody really nervous? Hi, can I call you back? I'm just giving a lecture. So usually over 28 millimeters of mercury. Right?
28?
28. Greater than 28 millimeters of mercury is really diagnostic of an intra-abdominal. Usually normal compartment pressures in an abdomen is usually around 12 millimeters of mercury. But when you get up around 28, that's when you know there's a problem, okay? So what's the treatment?
one question.
Hmm?
You have to paralyze the patient in order to do the
So
bladder?
you may not have to, right? But this now goes into what is the treatment. So you have a patient who's developing compartment syndrome, who's adequately sedated, who may not be paralyzed. You make the diagnosis, so what's the next step? The next step is that you chemically paralyze the patient, right? You take away the abdominal wall, right? So you relax the muscles in the abdominal wall, right? So that's a temporary medical management of the patient with compartment. The first step is to chemically paralyze them, right? Which is what we do, right? So we chemically paralyze the patient. We see what their intra-abdominal pressures are. We see what happens to, you know, the pulse variation on the arterial line. We see what happens to the urine output. You know, if that still doesn't help, then what do we do?
Release the tension.
You know,
Surgically.
you open the package, right? So you open the abdomen, you release the abdomen, okay? Let the fluid come out, right? Let the bowel come out. Put it out there, release the compartment.
But how
Okay.
the chemically sedating patient will release the tension?
Because you
From
take
the
away
abdominal
the
wall.
abdominal wall. So when people are
I
operated
see.
on,
You just
right, they get
relax them.
sedated, they get paralyzed. You know,
Right.
if you're ever in the operating room, the surgeon is fighting, trying to retract, and they can't retract because the patient's not adequately paralyzed, and you know the muscles get rigid, right? So you chemically paralyze them to release the abdominal wall to decrease the pressure inside the abdomen. So that's why we use muscle paralytics in a patient who is developing and/or who has a compartment before they go to the operating room, or sometimes we've done it right in the
Right.
ICU where we just open the abdomen right in the intensive care unit. Okay? So, but you all, I mean, the nurses can drive this, right? So you're taking care of the patients, right? You can recognize that you can look and say, well, wait a minute, urine output's down, peak airway pressures are up, the abdomen's tense. You go and grab the resident by the back of his shirt and you bring him into the room and say, compartment, we're measuring the pressure. Okay, pressure's greater than 30. Patient's got a compartment. What are we doing now? Right? We're paralyzing the patient. You open the abdomen. You know, so you all can drive that, right? And you can recognize it and you can drive it and you can you can diagnose it and you can push things along, you know, by doing that because it's not something that I don't think is within out of your scope of being able to do that, right? Like a lot of things, right?
Definitely.
Right, with looking at somebody who comes and has,
What's your assessment?
yeah, your assessment is patient is
Right.
dropped his O2 sat, they're hemodynamically unstable, right? I think they're high risk for, you know, for pulmonary embolism. What are we doing, right? The patient has blood in his NG2, they're hypotensive, they got melena, they got a GI bleed. What are we doing, right? And the same thing here for intra-abdominal compartment. So all these things, you know, I think are driven by the fact that you don't need somebody to come by the bedside and tell you what's going on. You all know what's going on. I think you need to speak up more, you know, and drive these things, you know, because as we get more and more, because now we're talking about PGY1s in the ICU.
What?
Yeah, it's coming.
Oh,
It's
God.
going to be the end of the year. It's not going to be the first year, but the end of their PGY1 year, they're going to start coming to the ICU, right? And more importantly, PGY1 at the end of the academic year is no different than PGY2 at the beginning of the academic year, right? So, you know, our hard labor, you know, that we put forth in terms of educating and training residents is like what we do. Like, first 6 months, like, you know, live in the ICU, you know, and then the second 6 months, things are a little bit easier because, hey, we've trained the PGY2s, there's things they can do, we don't need to be there all the time, you know, so that, and the nurses, right, it's clear, you all spend 90% of your time at the bedside, or 95% of the time at the bedside, taking care of the patients or recognizing problems and knowing what the issues are, right? And the resident, or we, you know, making rounds, we're there about 5-10% of the time. So you guys are really the front runners of driving of care and caring for the patients. So, you know, I think it's, you know, more important that you're not afraid to speak up and tell people what you think, right? It's important. Okay. Questions?
That was so good, Ronnie.
Yeah.
Oh my God.
That's the question.
There's-
Just the politics of everything?
It's
or
not the
just
politics.
way
It's
going?
probably not a bad idea to get them acclimated. So if we can get them up as PGY1s and then give them the FCCS course and give them some, they're not going to have any call responsibility. They're just going to be kind of like an observer or somebody who's in the ICU is going to be observed.
I can only do-
But, you know, the nurses, look, I came here, I knew nothing. I arrived here, I walked in the door, they said, who are you? I said, my name is Ronnie. I'm a PA. They go, what's that? The answer is, no, you're not. You're a resident. You're on call in the ICU tonight. Get upstairs. I'm like, okay. You know, and I walked into the ICU and all the nurses went. And I went, let's be clear. I don't know anything. Tell me everything you know. Teach me everything you know. And nurses were very good. They taught me, you know, about transducers and how to calibrate and how to do this and how to do that. You know, and they could recognize certain things and tell me, You know, and that, even to this day, you know, you all don't realize it, but there's certain things I pay attention. You may not think I pay attention, but there's certain things you say to me that I may not even be thinking about, that turns on a light bulb in my head and takes me in a completely different direction, just by things that a nurse sometimes will say to me. So, you know, did you look at this, or what about that, or, and I'll be like, you know, the resident's somewhere out in left field, has no clue, right? And the nurse goes, I'm like, sure, you know, and so, I mean, it happens, you know, so I think that you guys are the gatekeepers, you know, the patients. So that's why I thought it was important to go through this, you know, course, and everybody walk away
Mm-hmm.
knowing a little bit more. So now we'll take the quiz.